Hi, I'm Dr. Jack Shilling. I'm the Director of Hip and Knee Replacement at Bone and Joint Institute in Camden. And I'm here today to answer some questions regarding issues you may have with hip and knee arthritis and hip and knee replacement specifically. We've already got some questions in the queue here, so I'm going to go ahead and just get started. And feel free as we move through the hour, if something strikes your fancy that you haven't heard, to go ahead and enter a question, and we'll see if we can get to it. Alan asked a question as to who should have hip replacement surgery. That's a fairly broad question. I think the first thing you have to do is you have to have a diagnosis of hip arthritis or avascular necrosis, any of the disease processes that can cause your hip joint to wear out. That can typically be diagnosed with x-rays and sometimes with MRIs. Once the appropriate diagnosis has been assigned, then it's a question of how the symptoms from the disease process affect your ability to live your life. So when it comes to joint replacement in general, you have to have the right problem, but you also have to have a fairly miserable quality of life and significant pain and restrictions that you're not willing to live with. It's important to remember that hip and knee arthritis are problems that are livable in a sense. This is a quality of life surgery, and most of the people who have successful joint replacements have typically found themselves in a place where they have a diagnosis but are unwilling to live the life that they want, and they're fed up. And when all non-surgical treatments have been exhausted, then they move on to consider an operation. These are very common and very safe operations, but nonetheless, they're still surgery, and surgery has to be respected. There are going to be risks of infections and blood clots and anesthetic complications that can, but usually don't occur. But these considerations need to be taken. And again, you should have the surgery when you really feel that you've got no other options and you're tired of your quality of life restrictions. Another question that's come through is what are some alternatives to hip replacement? Well, alternatives, the functional word alternative, hip resurfacing is a partial hip replacement, if you will. If you stay away from an operation in general, there are injections that can be tried, medications that can potentially be put into the joint to try to improve symptoms. Remember, going back to some of the things that we said just a few minutes ago, arthritis is a problem that really only requires surgery when the pain and the disability is intolerable and there are no other options to be that you're willing to consider. So I think the alternatives would include injections. Some patients may be candidates for partial hip replacement, but ultimately, if you've got bad hip arthritis and it's significantly affecting your quality of life and you are tired of those restrictions, the alternatives to hip replacement are few. Thomas asked, what can be expected immediately after surgery? Obviously, there are several ways to perform a hip replacement, and many surgeons in this area and across the country do it very, very well. Just about all techniques for hip replacement surgery have improved over the years to the point that we are getting people up and out of bed on the same day of surgery, and many people are going home the next day or 2 days down the road. I would say that 80 to 85% of my patients go home by the second day. So there is pain from the operation, but hip replacement surgery is interesting from the standpoint that the significant arthritic pains that people experience prior to the surgery, they can oftentimes tell, even within several hours, that pain isn't there anymore. There's a muscular pain from the surgery, a soft tissue pain from the surgery, but some of the pain that they had prior to surgery is no longer present. Knee replacement surgery tends to be a bit more difficult of an operation for the patient from a pain perspective. The knee joint, unlike the hip joint, tends to want to get stiff, and there's a lot of work in physical therapy, a lot of aggressive work that needs to be done in order to have a successful surgical outcome. So a lot of times patients really don't want to push themselves because it hurts too much, but the reality is that without that pushing, particularly through the first several weeks, the outcome can be compromised. So my message is that these are great operations, and you do get a lot better very quickly. I tell all of my patients, I expect you to be 95% improved between the first 4 to 6 weeks. And it's very patient dependent as to who gets better quickly and who doesn't, based on preoperative conditioning, weight, extent of arthritis, how long the disease has been present. But by and large, people get a lot better pretty quickly. Here's a question about the opinion of the quad-sparing knee versus traditional knee replacement surgery. This is a very interesting and very, how should I say, hot-button topic, for lack of a better word, because there are many people, myself included, that feel that there has been really no proven benefit to the quad-sparing knee versus traditional knee replacements, having done both of the operations. The quad-sparing knee has been around for years. And has been adopted by several surgeons recently as an alternative. I think it is that. I think it is an alternative, but it has not certainly been proven to be better. And truthfully, I think that any patient with a well-qualified surgeon doing quad sparing or a traditional knee replacement can have outstanding results. So I would not hedge your bets on the fact that one surgery is the magic surgery versus another technique, because I think that there are several ways to do these operations and have them done very, very successfully. Lori mentions that she has some bad bone-on-bone knees. And just to be clear, what Lori means when she says that is that the cartilage in her knee is gone and the bones are rubbing on each other, which is what happens in significant arthritis. I'll digress for a second and just explain that we throw the word arthritis around a lot, but what we really mean when we talk about arthritis, particularly in the hip or the knee joint for our purposes here, is that the cartilage cushion between the bones is gone and that the bones are rubbing on each other, and that causes friction and that causes pain. And ultimately, that leads people to seek treatment, whether it's injections, whether it's physical therapy, whether it's eventually a joint replacement. Lori says that she knows that her knee needs to be replaced, but that she's also got some medical problems that make her a little bit nervous about the surgery. Well, I would say this, that when it comes down to any surgery, medical clearance is a piece of the puzzle, where anyone that I do an operation on is going to see a medical doctor, their medical doctor, a cardiologist, and in this case, we're dealing with a congestive heart failure condition. Well, we may not be able to cure congestive heart failure before the surgery is completed, but we can certainly do things to try to get it optimized. And once we've done a formal and very aggressive medical evaluation prior to the surgery, we can assess what the individual risks are for any patient and then have a conversation about whether the risk or the benefit of the surgery actually makes sense. Certainly when you have a condition like that you have to work through during the rehabilitation, it can lengthen your recovery. There's no doubt about that. But there are safe ways to pursue that surgery in the right case. And I think it comes down to finding the right surgeon and having a conversation about these conditions and situations so that they can be maximized and go from there. And the last piece of that question, are there better options among joint replacement or among replacement joints, excuse me? I mean, I can tell you that I've been doing these surgeries for 16 plus years, and I've used several different companies' implants. And I think in 2015, there are many implants that are very, very good at getting this job done. So to say that there is one that is significantly or magically better than another is probably not true. I think it's about finding the right surgeon, someone that you trust, someone that you can discuss, and having an honest conversation about risk-benefit and going from there. And I think that things can be very, very successful for you. A comment about cemented or uncemented prosthesis better. Well, it depends on what joint you're talking about, because ironically, when you're talking about hip replacements, in 2015, most hip replacements are done without cement. We have, through the years, developed the correct geometry for some of these implants and the correct materials that the implants are made out of, so that they fit into the bone well, the bone grabs them, the bone grows onto them, and loosening is something that is just not nearly to the extent that it used to be, and the cement is not necessary to hold them tight. On the knee replacement side, the standard is still a cemented prosthesis, although there are newer cementless designs being used all the time that have been having great track record. I tend to look at this as hip replacements. You're putting things in the bone and you can fit the parts into the bone and they tend to stick well with the right metal. When you're putting pieces on the outside of the bone, I still very much like to use some cement as a grout to make sure that the fit is tight, and I think it gives better longevity for the implant. What criteria or health issues should be considered constraints for joint replacement? Well, again, that's a fairly broad question, and I think it goes back to what we were talking about a few minutes ago. I think that every patient brings their own separate set of variables to the table, and there are situations where I will put someone through medical clearance issues and find out that in the end we come to the decision together that the risk of surgery really outweighs the benefit of the surgery. But that is less likely than what you think. I mean, there are a lot of medical conditions that we just can't cure, but we certainly can usually work hard to get people's situations maximized. You know, diabetics can have tighter control than maybe they did previously, making sure high blood pressure is well controlled. Doing things we can if someone has some baseline kidney disease or liver disease to try to improve those things. You may not be able to cure the problems, but you can make those a little bit better to increase the likelihood that you'll be successful. So my message is that if you have health concerns, you come and you talk about it, and we look at the x-rays. We decide first and foremost whether you need an operation. Then if you do need an operation, really put you through the paces to decide what your relative risk is and then move forward. And ultimately, it's a collaborative decision. It's your decision as the patient, but it's a decision that we make together to try to make sure that we give you the best possible outcome that we can. Jeff asks if there's an age limit for hip replacements, and I'm not sure whether he's asking high or low, but we can address both of those issues. You know, it's interesting that in the general population, the lower age limit for hip replacements gets lower and lower all the time. I think as the population becomes and tries to stay very, very active, and as the implant designs have improved through the years and the surgical techniques have improved through the years, the age limits for which I will consider doing a hip replacement are less and less and less all the time. I think the same thing is true on the opposite end of the spectrum. I very much look at these at patients individually. So I've met 90-year-old patients that I would rather operate on than some of the 60-year-old patients that I've met. So I think you really have to look at the case on an individual basis. I will say that in general, we would like to hold off as long as we possibly can to do the surgery, because ultimately these implants are just that. They are mechanical devices, and the reality is that they will have a lifespan. So the younger you are when you have your first surgery, the higher the likelihood that you'll need an additional surgery when the implants wear out. Again, I think that the answer is you take each case on an individual basis and you do everything that you can to hold off as long as you can. Susan mentions here that she's been diagnosed with significant arthritis in her hip and was advised to have a hip replacement. And at 61, she was just wondering about recovery time. I mean, we've touched on that a bit. Susan mentions, as I'm sure a lot of patients would, that I'm very scared of having this done, but I'm in a considerable amount of discomfort. And I think that as I was mentioning before, you know, no matter how good we are these days at doing these operations, you can never get too, the word I like to use is cute, I guess, but you have to respect the operation. Now, that doesn't mean that you should be so scared of the operation that you don't have it done. I mean, my advice is that if you've got bad arthritis and you are in a significant amount of discomfort and your quality of life is being restricted, that this is an operation that probably will do you a lot of good. And we work very hard, as I've said in some of these other questions, to get people medically maximized, to make it as safe as possible. And while surgery is surgery and there are no guarantees to success in anything in this world, the success rate for hip replacement surgery across the board is far beyond 95%. So I think that the odds are heavily in your favor that you would do quite well. And most people, when they are in the situation that Susan finds herself, when they finally get the surgery done, their response and their thoughts are, boy, I wish I didn't wait as long as I did, and I should have gotten this done sooner. So again, you make the right diagnosis, you appropriately plan for the surgery, and chances are things are going to do just fine. So alternatives to joint replacement for people in their 40s whose knees have been described as bone on bone. This is from Elizabeth, and we touched a minute ago regarding the issues of implant wear. And the reality is that the younger you are when you have your first surgery, the more likely that it'll wear out. It probably won't last as long because the young patient tends to beat things up a bit more than the older patient would. And you may find yourself needing additional surgery. So I think it's appropriate to be concerned about having a surgery like this done when you're too young. Now, beyond that, the simplest treatments as far as alternatives go, I think it's about lifestyle issue. First and foremost, you do everything you can through the pain to deal with keeping your weight down and keeping your physical conditioning levels as high as they can be. I mean, that can be problematic because as you get a more advanced arthritic condition, the pain can sometimes prevent you from actually being able to be active. Tylenol, nonsteroidal anti-inflammatory medications, the Advils, the Alevs of the world, there are many different kinds of medications that can be used, again, to decrease that inflammation, to try to keep people active. When those things are not particularly useful, periodic steroid injections can be helpful, as can lubricating shots with viscosupplementation. Typically, when these things have all been trialed and you still find yourself in a situation with significant pain and significant activity restriction, you're forced to consider surgical alternatives. In some limited cases, arthroscopic debridement can be beneficial, but in a bone-on-bone case, you may very well be forced at that point to consider knee replacement surgery. Again, as I've said, if you get to that place and you're in an intolerable situation and you just can't wait any longer, look, you live your life and you get done what needs to get done and you move on. But certainly trying all of those other things ahead of time and trying to hold on as long as you possibly can makes good sense. Susan asks another question regarding knee replacements, and would I recommend doing both or one at a time? And again, that's a really excellent question. I do single knee replacements, I do bilateral knee replacements, and I think that the decision to do one or both really again comes down to an individual decision of the patient. I think with success in bilateral knee replacement, you have to be selective with the patients that you choose. Some people will do better than others, and I think it's about making the right diagnosis. I think it's about finding someone who's healthy enough to have both done at the same time, and it's about having two really bad knees at the same time and really mentally being prepared and tough enough to push yourself through the significant therapy it's going to take to get to where you need to be. But I will say that while I probably do more single knees than double knees, some of my happiest patients are people who have had both knees done at the same time. So I think you shouldn't be afraid of it, and I think that it's hard to blanket that one is better than the other. Like a lot of these things, it really comes down to the individual. And having that conversation with your surgeon is what likely to me makes the most sense. Elizabeth mentions here that she's seen commercials for knee replacement implants made for the woman's knee. And is there really a difference, or is that just a marketing ploy? And I would say this. I think that when it comes down to the woman's knee, I have used the knee that is, quote, designed for women, and I have used regular knees on women, and they have done just fine on both, with both. The women's knee has a femoral component, the piece that goes on the end of the thigh bone. That's slightly smaller. and in certain situations could have some potential benefit, but I can tell you that there's never been a research paper that proves that that's true. So like a lot of these things, I would say it's about finding the right surgeon that you trust. It's about making the right diagnosis and the right decision for yourself. And I think that the implant is a piece of the puzzle, but really I can use many different implants on many different patients and have very, very successful outcomes. John says that he is a very active person and wants to get back to a very physical activity, and is hip resurfacing the way to go? And I'll tell you, that's a tough question, because in the grand scheme of things, hip resurfacing was initially thought to be for something just like what you're describing, a lifestyle just what you're describing. Partly because it's a very large ball and it is a very stable construct, but it's a metal-on-metal construct as well. And I think that what you have to be careful when you think about hip resurfacing is that, number one, it is a metal-on-metal implant. And the studies that have come out in the last few years have really taken some of the wind out of the sails of resurfacing, because there have been some significant downsides in certain patients who have metal-on-metal hips. And it's very hard at times to predict who those people are going to be. And there can be, although the percentages are small, some pretty significant complications that go with metal-on-metal implants. So when you're considering resurfacing, you have to take that with a grain of salt just based on those facts. Beyond that fact, I think it's important to understand that if you get back to an active lifestyle, no matter what type of hip you've got, it is going to wear. And when it needs to be revised, one of the issues that was brought up with hip resurfacing through the years is that it is bone preserving, and if it needs to be converted to a hip replacement down the road, that is an easier conversion. And and I can tell you that in my personal experience, that's not necessarily the case. So while there may be some people that benefit from that, a very active and very physical lifestyle is going to potentially be problematic with anything you put in, and that if you do go the route of a hip resurfacing, you just have to really understand that while you may be gaining something for certain longevity and wear issues with that, there are some downsides that can come with a metal-on-metal hip, and you have to just keep that in the back of your head. I can tell you that I don't do hip resurfacing. I did it for a while, and I've stopped doing it because of the potential concerns. There are other people that would disagree with that statement, but that's my personal answer to that question. I had a hip replacement 8 months ago, Diane says. How long for total recovery, and how long should I wait for the other hip to be done? Those are great questions. You know, I tend to think that hip replacement patients get better pretty quickly. And, you know, total recovery is a relative term. You know, I say to patients, look, I hope you have days where you forget that you did it. But to get rid of every stitch of pain and every bit of limp and things like that can take a while. And, you know, 6 months, 8 months, 9 months, I mean, everybody's different. It depends on physical conditioning prior to surgery, after surgery. It depends on activity levels. So those numbers can vary. But can it be 6 to 12 months to really get what you would view as a total or a complete recovery? And my answer would be absolutely yes. The best activities after hip replacement surgery, after knee replacement surgery for that matter, but certainly for hip replacement is walking. I mean, you need to get up and you need to be active. And the muscles involved in most of the hip replacement techniques, they get stronger with the active walking. So it works very synergistically. That's what you want to do, and you're making yourself better by doing it. So my advice is be as active as you can, and you will see a slow, gradual improvement. You know, for some people it's 6 weeks. For some people it's 6 months. It's just hard to predict, and you shouldn't view yourself as being successful or a failure one way or the other. You are who you are, and you just keep working to get a little bit better every day. And like I said before, 95+% of these patients, or patients that get hip replacement, do very, very well. The timeline can just be a bit of a variable. Waiting to get the other hip done and the timeline in between is also a bit variable as well, but my bare minimum is 3 months. I like to wait for people to sort of get through the first operation, get some physical conditioning, get some strength, get some balance, get some confidence back on the other side, have their blood clot risk sort of come back to baseline. And as you get to the 3rd month, people are starting to feel pretty good about the other side, and their recently operated hip has become the good hip, and they feel that they're ready to put themselves through another operation. There are lots of people that will give you lots of different answers to that question, but my personal opinion is 3 months, and I think that that's a pretty safe answer to that question. Let's see here. From Lynn, she asks, what are signs that a prior knee replacement needs to be redone? You know, I think that answer is, again, there's lots of things to look for, but generally speaking, if you had your knee or you had your hip replaced and you were doing very well, and then all of a sudden you start having pain that you didn't have before or swelling that you didn't have before, it's worth getting evaluated. And you know, it can be, when these things wear out, it can be the potential for the metal parts loosening themselves from the bone. It can be plastic wear, which is a bit more common. But the reality is that if you've had a period where you were doing great and then all of a sudden you're not doing great, it should be looked at. Now, look, if you have a hip or a knee replacement, we can all have a bad day here and there. I mean, today's a kind of rainy, lousy day. This is a day where everybody's joints hurt, no matter whether they've been replaced or not. And if you have a lousy day, but tomorrow's a better day, you know, not necessarily anything to worry about. But I think if you were doing great and all of a sudden you've got 7 to 10 days of, I'm not sure what's going on, and I'm having a hard time walking, I'm having a hard time doing the things I was doing, I feel like I'm going backwards, it's worth getting looked at. But simple things like pain I didn't have before and swelling that I didn't have before are oftentimes the very first signs that a hip may be wearing out, and some additional work may need to be done. Tamika asks, what is your opinion of cortisone injections as treatment for pain? And I'll tell you, that's an excellent question, because I think that if you listen to what we talked about before in terms of how you treat arthritis, and you go from where you start, which is my knee or my hip bother me, to I need a replacement operation. The real reason, and the most successful people that get the surgeries done, are people that have tried the non-surgical things and have proven to themselves that they don't work as well or as much as they need to. You know, some of that is, like I said, these implants wear out, surgery is surgery, there's risk, but I also think that there's a mental component where patients do better when they understand the process and when they see for themselves that I've tried some of the simple things that have been laid out and they just haven't paid the dividends that we wanted. And I think that then if you consider surgery down the road, you're more ready and more willing and more accepting of the things you're going to need to do for that to be successful. Now, that being said, steroid injections, I mean, first of all, cortisone is a term that we use as a general term for steroid injections. And, you know, truthfully, we probably haven't used cortisone proper since the Korean War. But there's many different preparations, more modern preparations of steroids that we put in joints every day, whether we're talking about hips, knees, ankles, shoulders, whatever. I think steroid-based injections for arthritis to decrease inflammation can be very, very successful, but you have to do them properly. And so, you know, to me, when I'm injecting people's joints, I look at this and say, look, 4 months is the bare minimum in between, and I really like to try to keep these injections to 1 to 2 a year if I can. And if you're able to have an injection like that and have it improve your symptoms so that you get back to a place where functionally you're doing well, your activity level is where you want it to be, there's no reason that you can't continue on that path for some time. Where you get into trouble with steroid injections is when you have too many too close together. You know, I'm not a fan of people that come and say, I had 3 injections in 3 months. I think that's a mistake. I think if you had an injection and it only lasted you 3 weeks, well, I'm glad that you felt better for 3 weeks, but that's not success to me. And I think that if that's the case that you're finding, that it's time to move on to something else. So to me, you know, too many steroid injections too close together. Patients will say to me all the time, you know, I hear that can damage the cartilage or damage the bone. Well, when you give an injection into a joint once or twice a year, the reality is that that's pretty unlikely to do significant damage to the joint. But when you're doing it once a month or closer than that, I think that you can run into those problems down the road. So again, my message is if you do them and they last a while and you can get away with 1 or 2 a year, I think that you can continue doing that for a while without any real significant recourse. And ultimately, arthritis is a progressive problem. The reality is what used to work over time probably won't work in the future. And when it doesn't work again, there may be a time that you need an operation. But again, at least you've walked down that path and you know what's been successful and what hasn't been successful. And that mental approach to this whole thing tends to make, I think, patients do better in the long run. A comment from a guest says that you did my right knee, and I panicked there for a second that someone was going to say that it was doing terribly, but it's doing well, and now my left knee is starting to hurt. Do I need to wait before I get the left knee done? And I think that the simple answer to that question comes back to how long it's been since your first knee was done. And if it's been 3 months and you're having a good result with the right knee and you'd like to proceed with the left, if the right knee is the quote good knee at this point, then we come back and we revisit that issue and talk about getting it done. So my answer would be 3 months. Mary asks, states that she's going to have a hip replacement, and is Zimmer, a specific implant company, the best? And I tend to try to stay away from discussions about which company has the best stuff, because I think that it's a dangerous game to play. I think that all of the major implant companies, and there are several, have very, very good implants. And to be frank about it, I think that one of the worst things that's occurred in my profession in the last 5 to 10 years has been the direct-to-patient marketing that's occurring from the companies trying to sell their implants to the consumer and leaving me out of the loop. I mean, I think that what you should do is have a conversation with your surgeon about the surgery and why they choose the implants that they choose. And I think that that's the best place for that conversation to occur. And I think, again, I've used implants from that particular company. I've had fantastic success with them. But that's not to say that there aren't other implants from other companies that would also provide excellent results. So my message is have a conversation with your surgeon and go with and trust their judgment regarding which implants they're using, because there are many that can provide very, very excellent results. What is the best way to choose a doctor for hip or knee replacement? Well, that's a loaded question. I think that we're lucky in Philadelphia to have a lot of very, very competent surgeons in many health systems that do a good job. Now, obviously, I do this kind of work, and I take a lot of pride in the fact that I think I do a pretty good job at it. I think that word of mouth is always a good thing. I think if you have friends that have had the surgery done and have had excellent results, if you've been in a certain health system and you've had good results, I think that's a good way to approach that. I really tend to go with word of mouth. If your friends have had good success and people have done well, there's reasonable odds that you're going to do that. I think another good way to approach that is get several opinions, because as I said, there are lots of people that do these things well. Sit down and talk to people about what they're going to do and how they're going to do it. And if you don't like the answers that you're getting, get another opinion. I think if you see 3 or 4 or 5 people about these things and you're getting the same answers, it at least gives you the confidence to know that you're on the right track and doing the right thing. And then you go with your gut feeling about the personalities that you think you would work best with. I try to be, very patient friendly, and I try to have, and invest a significant amount of time in getting to know my patients and spending the time to explain things to them. And I think that matters. It matters to some people more than it matters to others. But getting a feel of the individual doctors and what their practice patterns are and what their style is, I think is another good way to do that. And you can't really know that unless you spend some time with a few different doctors. How do I feel about Synvisc? Well, Synvisc, again, trying to stay away from brand specific. Synvisc is one specific brand of viscosupplementation. So we'll talk about viscosupplementation in a very general heading. So these are lubricating type shots that go into arthritic joints, particularly the arthritic knees. That's where they're most commonly used. As of today, viscosupplementation is not FDA approved for the hip. But it is approved for the knee, and again, that's where the industry has focused. I have seen viscosupplementation be wildly successful for patients, and I have seen it do absolutely nothing for patients. And so The good news about it is that I think that from a case-by-case basis, that the risk of viscosupplementation is very, very low. There can be some unfortunate results of allergic reactions like there is with any medication, but the reality is that in most cases you either get better or you don't, and the real long-term side effects are few. So when you're approaching an arthritic knee situation and you're trying to avoid an operation, that's certainly a very reasonable thing to try along the path. And just like I said before, if you've done medication and you've done steroid-based injections and you've done lubricating type shots and viscosupplementation and you still find yourself in a situation where the pain is substantial, that the quality of life restriction issues that you've got are significant, then you've lived that. You've experienced that yourself. And when you then have to make some decisions about surgery, you have that much more confidence that you're doing the right thing. And putting yourself through, the risk of getting an operation. So how do I feel about it? I think it can be a very useful tool, but it doesn't work for everybody. But I think that the downside is relatively small in trying it. What types of metals are used in knee replacements? And if so, what are the pros and the cons of the types? I think that in modern implants, most of these metals are titanium variations, because titanium, for as durable and as hard as it actually is relatively bone friendly, meaning that it has the term we use in orthopedics is a modulus of elasticity that's similar to bone, and so the metal pressures against the bone don't create undue pain. There are issues, some people have metal allergies, and there are certain specific alloys that we will use to try to avoid the potential pitfalls of nickel allergy, but the reality is that I think most companies provide implants that are fairly similar in terms of the metallurgy, and so from a pro and con standpoint, it's hard to really have a conversation because I don't think there are many at this point. Let's see here. Let's scroll down here. Suzanne says that her son had a hip fracture at age 17, and he's now 28 and complains often of discomfort, especially when it rains. And should he look into the possibility of a hip replacement? And quite honestly, the right answer is you have to know what's causing his pain first. I mean, this could be a muscular cause, this could be a bone cause, this could be a cartilage cause. And so the reality is that the first thing you need to do is get an x-ray and have him evaluated by an orthopedic surgeon so that we can get an appropriate diagnosis. You can't really have conversations about treatment until you know what you're treating. So a plain x-ray of the hip is probably the first best place to start, followed by an appropriate evaluation, and go from there. He may be suffering from arthritic changes, he may be suffering some other things, but you really need to take some pictures in order to know that for sure. Here's a question regarding if you've had a hip replacement, will you always have a limp? I have a friend who had one several years ago, and even though she did rehab religiously, she has limped slightly ever since. Well, again, the simple answer to that question is some people do. Limps typically will come from one of a couple of different causes, but the most common ones would be either some persistent muscular weakness, or the potential for there being a limb length discrepancy after that surgery where one leg is slightly longer or shorter than the other. And a thorough evaluation of that would occur, or excuse me, would need to happen to really know that. Some patients also find themselves in the habit of limping, and I've had patients where their muscles are strong and their leg lengths are equal, but yet they limp for so many years before the surgery that they never retrain themselves to stop limping afterward. That's less likely, but nonetheless it can happen. It's also sometimes important to really assess someone's lumbar spine and as to whether there are any back issues that can contribute to muscle weakness around the hip. That could be the source of that. But again, these are all issues that can be evaluated by an orthopedic surgeon, and usually we can come to some conclusions about what the right choice is. The last thing I'll also say is that it's not uncommon for patients to do very, very well after surgery when they're doing their physical therapy aggressively, And then, if they have some other medical problems that cause them to become a bit more sedentary, a job change, a lifestyle change, weight loss, weight gain, and all of a sudden they find themselves limping because they got a little bit weaker than they were before. And occasionally an additional trip back to physical therapy can get them going in the right direction. So, just from asking that question and giving the 5 different answers that I gave you there, I mean, there can be lots of reasons why. So if she's frustrated by it, my advice would be get it looked at. There may not be anything to do, but there very well may be some things we can do. And so it never hurts to take a look. What are possible complications of joint replacement surgery? Well, that's a fairly broad question. When you get your joint replaced, the 3 things that I tend to think of that I talk to patients about are the risk of infection, the risk of blood clots. There is some risk of bleeding, as there would be with any surgery, and then the risk for additional operations being necessary down the road. When you're putting metal and plastic or metal and ceramic or metal and metal implants into anybody's joints, these are foreign materials. And if you get an infection in your blood, I mean, it can be as simple as a skin infection, it can be a tooth infection, it can be a urinary tract infection, it can be a pneumonia. But if you get bacteria in your blood, the bacteria tend to like to go and sit on these implants and create potential problems. And like I said, infection it can be a really significant concern, because if you get an infection around your joint replacement, sometimes you can't get rid of the infection without taking all the metal and the cement and the artificial pieces out. And that obviously is not something that we take lightly, and something that can have significant negative effect on the patient. So while the risk of infection after these surgeries is 1% or less, it doesn't mean that it doesn't happen. And if it unfortunately happens to you, it can be fairly significant. We talked about blood clot risk as well. Everybody who goes through an operation like this hip or knee replacement tends to be on a blood thinner after the surgery is done. And as the years have gone by, there are more and more different types of blood thinners, and the length of time that people are on the blood thinners has changed. I mean, generally speaking, the length of time you're on a blood thinner has shortened, because as our surgical techniques have become somewhat less invasive, and we're much more aggressive at getting people up and moving them around right after the operation, that motion and that activity by itself helps minimize risk as compared to years ago when people would be in bed for days. So, but it doesn't mean that the risk of clot is 0. And so that is, again, a small risk, but a risk nonetheless. And in my practice, I tend to really look at the individual patient and make an assessment during their medical clearance of what their real risks for clots are, and then select a medication that's appropriate for their relative risk. We talked about bleeding. I think, again, that with blood conservation techniques that have evolved and improved over time, our surgical techniques are better. The need for blood transfusion has become less and less and less after these operations. It doesn't, again, mean that you wouldn't need one, but I don't have my patients donate blood ahead of time. We use different medications in and around the time of surgery to help minimize the risk of blood loss. And again, less invasive techniques help there as well. And then the last thing that's worth discussing is that anytime you have a joint replacement, there's always the risk that you'll need additional surgery down the road. We've spent time during several of the answers to these other questions discussing the fact that these are mechanical parts that will wear out over time, and when they do, they may need to be replaced. So once you have your first one, the clock is really ticking on when you need, or if you need, your second one. And so you always have to go into this thinking that if I get my joint replaced, hip, knee, or otherwise, that there very well may be a time down the road where I need to get it revised. And the younger you are when you get your first one done, and the larger you are, and the more active you are, and the more aggressive your lifestyle is, it tends to shorten the lifespan of the surgery. So those are the major things that I would think about. And again, if you have a conversation with a surgeon about the operations, I mean, I tend to have that discussion with the patients every time, because those are 4 fairly predictable things to go through. What types of exercise are most suitable for someone with knee replacement? Well, you might get different opinions from different people that you ask that question to. I mean, I tend to say that the term that I will use, and then I'll explain what it means, is I like closed chain exercises. And by that I mean that, you know, your foot never leaves the ground because it minimizes impact. So if you're riding a bike or if you're swimming, those are closed chain exercises because there's no real impact where your foot is coming back down and striking the ground. Walking is certainly better than running when it comes to the open chain exercises. But regardless, what you want to do is you want to minimize impact because that's the thing that tends to wear the plastic out faster and it tends to potentially loosen the joints faster. So I'm a big proponent of cycling, stationary bikes, swimming. Those are all closed chain exercises that can keep you in good shape, but tend to not necessarily wear the joint out too quick and too aggressively. Here's an excellent question. I had bilateral knee replacements in September of 2014, and is it normal to hear clicking when walking? And my response to that is absolutely. I would tell you that at least 85% of people have a pet click, you know, because you've got metal and plastic pieces coming together. Some of it is the kneecap portion moving across the thigh bone piece, and the metal against the plastic can make some noise. You can get a little bit of scar tissue around the kneecap as it moves that can make noise by itself, including some cracking. When you're walking, sometimes the thigh bone and the shin bone will come apart a millimeter or two and then come back together as part of the function of a normal knee. And again, because these are metal against plastic parts on the inside, they make a little bit of noise. Generally speaking, the noises that you hear in your joints, if they're not causing a significant pain at the time they're occurring, they're very benign and you shouldn't worry about them. If they are very, very reproducible, if they are creating significant pain or swelling or other restrictions, there's no harm at all in getting these things looked at. But generally speaking, a little bit of noise is not something that I would be all that worried about unto itself. Joan mentions about or asks about recuperation time needed for a knee replacement. You know, I think that when I discuss timelines for recovery, particularly when it comes to knee replacement, you know, it's about having a conversation with the individual patient. Some of it is based on physical conditioning coming into the operation. Some of it is based on occupation and expectations that way afterward. You know, a standard answer through the years was usually, you know, you're going to be out of work for 3 months. I think that number has really come down over time. And for people who have more or less sedentary jobs, I get people back to work, you know, at a month, 6 weeks. Some of it's based on pain medication. Some of it's based on ability to drive. And it is very different from person to person. But I tend to tell patients, look, I'll work with you on this. And if you're making the appropriate progression, we will get you back to work as fast and as safely as we can. Now, you know, if you have a very physical job, if you're, you know, a construction worker, you have doing some manual labor, I think the right answer is, you know, take 12 weeks off. If you've got to ask for time off of work, you're much better off asking for a little bit more time off and then giving it back than it is if you tend to ask for 3 weeks and then need 6. Employers tend not to like that very much. But generally speaking, I think that you can expect a significant improvement in the first 4 to 6 weeks. And depending on your job description, you may be able to get back around that time. If not, you know, 8, 10, 12 weeks is certainly reasonable. And I would say most people are certainly back to whatever job they have by around 3 months. I've been told by my doctor that I should have a hip replacement, but I'm an active climber and hiker. Do you think that I will be able to continue my normal activities after the surgery? Well, I'll tell you that I would need to have a conversation with you one-on-one to really be able to understand just how active you are and how aggressive that you are planning on being. But I tend to tell my patients in that scenario that you ought to hold off as long as you can, because it's very hard for me to know how long, how well you'll be able to do everything after the surgery in terms of certain motions and in terms of certain activities. And climbing and hiking tend to beat these things up. And so my personal bias is that I don't want you to burn through your first hip replacement in a very short period of time. That doesn't mean that I wouldn't do it in the right person. In fact, I can tell you that I have done surgery on people just like you. But it's a conversation, because I think it's important to understand really the risks and the benefits of the expectations of the surgery, and what it really can do for you. But I would tell you the same thing that I tell every patient, which is that I really think you ought to be in a mental place where you feel like you can't live with this any longer. And if you get to that place, then you get it done, and then you work your way back. And I have a lot of skiers, and I tell people, look, if you're going to have this done, ski the trails. Just try to avoid the moguls. I mean, there's ways in most activities to sort of modify what you want to do, where you're still doing the things that you want to do, but maybe not to the extent or to the extreme that you might have done them before. And there's oftentimes, if you work with a patient on these things, a very safe middle ground where you can get out of it what you want, but you're not beating things up unnecessarily. That involves a conversation. So that would be my best guess, is to try to have that conversation. Ed asks what research is being conducted on joint replacement, and that's a big question. I mean, there is research going on all the time, whether it's looking at individual joint replacements and seeing how well they do over time. What is the track record on this implant versus that implant? What is the track record of this material versus that material? These are evolving times and evolving answers to these questions. I will tell you that where this question might be going is, and patients will ask me this from time to time, is there an alternative to joint replacement coming down the pike? When it comes to cartilage health and things like that, again, understand that joint replacement generally stems from arthritis in a joint, which is cartilage wear. The tread on the tire is wearing down and the bones are starting to rub together. If there are major changes to joint replacement that comes down the pike in the future, it may well be tied to what research we're doing on cartilage preservation or regrowth, where we're able to preserve the joint and move away from joint replacements. And I can tell you that while there is some very exciting research being done with cartilage, that we're really not all that close to that taking the place of joint replacement moving forward. And I just don't see any significant design changes coming down the pike that radically alter the way we do joint replacements. I mean, we're doing less invasive techniques, and we're trying different materials, different metals, different plastics. But I oftentimes will kid with patients and say, look at this x-ray that was done in 1980, and if you look at it against one that I did yesterday, in a very general sense, they look very similar. And that's because while we've built a better mousetrap and tweaked things a bit, a lot of the designs have stayed true. So things are getting better all the time with these implants, and the expectation is that the longevity gets better and better all the time. I mean, there are implants out there that have 20-year data that says, boy, the survivorship's 96+%. That's pretty good. But we're always working to get better and always trying to, like I said, to build a better mousetrap. So that research continues. Where can people find more information about joint replacement surgery? I think that the best place to find that information is face-to-face with your doctor. We live in an information age where the internet is a wonderful tool. Look at what we're doing today. I mean, I'm able to get a message out. I'm able to have conversations with many people and get questions answered from remote locations. It's a fantastic forum to be able to do that. But at the same time, you have to be careful when it comes to blogs and posts. And WebMD is a great resource, but these are very general statements and general topics made, and oftentimes, even when they're specific, they're very opinion driven. And that's also true of when you're sitting in front of the doctor. It's part of why I said before that getting multiple opinions about these things always makes good sense. So I think that it's healthy and appropriate to look on the internet and sites like WebMD or other informational websites for patients to get some information. You can look at implant websites and get some information. You can go to the news and you can read the newspaper and magazines. Again, understand that in all of those forums that there is a spin. You know, somebody is trying to get a message across to you as the consumer. And hopefully the place that you get the least of that is in a one-on-one conversation with your doctor in the office. So while I think that we live in an information age and there's lots of places to get it, I still believe that the best place is in the orthopedic surgeon's office. Debbie asks if they still make long incisions and use staples for knee replacements, and that's really a good question as well, because you know, I think, again, surgeon to surgeon to surgeon, these things vary. And you can have excellent outcomes with many surgeons doing things many different ways. I will tell you that the, quote, long incision and staples, I mean, the incisions that I've used over the years have gotten smaller and smaller and smaller. Everything I do is less invasive than what it once was. There's absolutely no doubt about that. I will use staples in most patients still to this day. There are other people that do different things. You know, there are suturing techniques to try. I mean, I think the surgeon finds a way that they can be comfortable about having a wound that heals, because again, to me, infection is your mortal enemy and you want to have something predictable that heals. I think there's lots of ways to make that work, but I would say that in general, the incisions we use are less invasive and the techniques we use to close are better and better all the time. Jake asks, what's the best way to prepare for knee replacement, and are there things I can do in advance to help the surgery be more successful and the recovery shorter? And I think that's a really excellent question to go through here as we near the end of the hour, because you know, the reality of insurance is that the third-party payers really, everybody's plan has a certain fixed amount of physical therapy that they're going to be able to have. And so while I would love to say that going to prehabilitation before surgery is a useful tool, most of the time in the modern world, we just don't have enough visits to allow people to go to formalized physical therapy ahead of time. So prior to surgery, anything that you can do to keep your weight down and to keep yourself in the best shape that you can be kept is a really good answer. And I think if you show up in reasonably good shape, you will tend to see that no matter how your surgery is done, no matter who does your surgery, your recovery with the postoperative rehabilitation tends to be faster. And I really am a proponent of using the therapy for the post-surgical work in knee replacement particularly, because, as I said, knees tend to get stiff. You've got a limited period of time after the surgery is done to get range of motion established. When you get your knee replaced, you want a knee that doesn't hurt as much. You want to walk without a limp. You want a leg that's strong. These are all things that can get better with time, but I can tell you that if you find people that don't like their knee replacement and you exclude the unlucky few that had an infection, I would argue that 99% of the people that don't like their knee replacement don't like it because it's stiff. Don't like it because they can't get all the way straight or they can't bend back. And when you don't have appropriate and full range of motion in your knee, it's impossible for the leg to get strong. It's impossible for you to walk without a limp, and ultimately that leads to pain. And you wind up over the course of several months very dissatisfied, and it's unfortunate. So again, excellent strength, range of motion, and weight reduction prior to surgery, and aggressive physical therapy after surgery. And I think if you do those things, that keeps your recovery as short as it can be and likely will lead to a pretty successful recovery. So those are the best recommendations that I can give from that. But you know, when you get your knee replaced, just be pretty prepared to work. I can't stress enough how important it is in those first 6 weeks to really grit your teeth. There's some blood, sweat, and tears working with a physical therapist to get you to where you need to be. But if you put it in and you plow through that pain, you will do just fine. I think we're coming to the end of the hour, so thank you very, very much for all the questions, and I hope it's been helpful, and I'll be happy to see you at Cooper if I can be of assistance. Thanks again.